Good morning, everyone. So we're going to get started again after the break now. So my name is Dr. Katie Scott. I am a clinical neuropsychologist with OCR, and I specialize in concussion. So that's kind of the general topic I'm going to be presenting on today. We had a recent concussion consensus statement that came out related specifically to sport-related concussion. And that's really the general framework that I'm going to be using today as we kind of go through updates and sort of where we are related to the science and clinical practice of concussion. So just some objectives for my presentation today. As I mentioned, I'm going to be using this consensus statement that came out in June of 2023 as sort of the framework for talking through these updates. So I'm going to briefly touch on just the process that was involved in coming to that consensus statement, and then the ability to identify some key points from the updated consensus statement, and then consider ways to take those updated key points and integrate them into clinical practice. I do just want to note and emphasize that this consensus statement was really specific to sport-related concussion. But I do think that the general principles from this consensus statement can be applicable to concussions that occur outside of a sport context. In my practice, I see a good mix of both, sport-related concussions and then those injuries that happen for other reasons. And would really say that I kind of approach recovery and that process really similarly, regardless of etiology. I recently had a patient come into the office who sustained her injury in a slip and fall, and she said, my neighbor was a little concerned about me coming to see you because she said, I think that person only sees athletes or only sees sports. And again, just really feel that what we know about concussion recovery from the sport-related literature is still very kind of generalizable and applicable regardless of the mechanism of injury. Just to kind of give some context here, I think it's helpful to consider sort of how much new research has come out related to concussion and then sport-related concussion over the years. So what you see here is just sort of a general, like a breakdown of PubMed searches in different decades since the 1970s of concussion and sport-related concussion. And if you look at these numbers, what the data tells us is that really 74% of published research in the area of concussion and sport-related concussion has come in the last 13 years. And already in our current decade, so the last 3 years from 2020 to 2023, that accounts for 32% of the research in these areas. And so that's a lot of new information and kind of fast-moving dissemination of information, which is part of why I'm here, to kind of help to provide, again, sort of where we are, kind of state of the science on this topic that is obviously, again, just lots of new research. So some background on how the consensus statement came to be. Essentially, there were expert panels that were broken into kind of 10 general subject areas. And from those expert panels, there were systematic reviews that were developed. The manuscripts from those systematic reviews were then submitted for peer review with the British Journal of Sports Medicine. And that was approved for publication again in June of 2023. It's a long process that really began back in 2018, and the consensus statement, or that those expert panels were really actually supposed to convene in 2020, and I think we all know what happened and delayed that process. So with COVID and travel restrictions and things like that, those expert panels did not convene until 2022. And so again, sort of a delayed process to getting this statement out. What's really great about this statement is that there was also development of some freely available tools related to assessment of concussion, monitoring of concussion recovery that are, again, openly available through British Journal of Sports Medicine. The consensus statement too and the resulting systematic reviews are also freely available. So as we talk through, one of the things you'll recognize is that the expert panels demonstrated a real commitment to using words that begin with R. So the previous consensus statement, we had 11 R's of concussion, and now we're at 12 R's of concussion. Some of these really make sense as sort of title topics. Some of them, I think there was probably some creativity in finding a word to kind of fit that framework. I am going to touch on each of these topics just at least briefly. The ones that I've bolded I think can be most applicable to sort of the you guys here as an audience, of PTs and primary care and things like that. So primarily that reevaluation, rest and exercise, referring, rehabilitating, the recovery process, and then that return to learn and return to sport process. So starting off, they did update the definition of sport-related concussion. Interestingly, the definition did not, so with those expert panels, to make a formal kind of recommendation in the consensus statement, had to reach an agreement of 80% of the consensus group members. And I think the percentage here was like 78.2% or something like that. So actually didn't rise to the level of that kind of broad support that they were hoping to aim for. There weren't big changes made to this definition, but essentially concussion is a TBI caused by a direct blow to the head, neck, or body that results in a force that's transmitted to the brain. That initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow change, and inflammation in the brain. They note that symptoms may present immediately, or these injuries, we do know and understand, can evolve over minutes, hours, and even within a couple of days of an injury. Typically, these symptoms resolve within days, but may be prolonged in nature. They also emphasize that with the diagnosis of concussion, we don't see abnormality on standard neuroimaging studies, so like CT and MRI. There's been a lot of work in the development of like advanced neuroimaging techniques, biomarkers like blood and saliva. And what we know at this point is that those seem to be useful in research protocols, but certainly have not yet gotten to a point where those are things that seem to be useful in clinical practice. Still really trying to understand what we see from those kind of more advanced biomarkers, what that translates to clinically, and then also just the kind of, frankly, being just available for clinical use. So this is, again, just a sort of breakdown of what we see clinically in terms of how people present when they have concussion. And generally speaking, symptoms break down into cognitive, physical, emotional symptoms, as well as potential change in things like sleep quality, ability to fall asleep, or sleeping too much, things like that. There's certainly been a lot of work around how do we reduce concussions, how do we prevent them? And I field a lot of questions in office from people about different kinds of products that are developed. The Q collar is like really in vogue right now, things like that. What I typically share with, it's usually like parents and kids that are asking about that, is the empirical, good, strong empirical support for those kinds of products is pretty limited at this point. And then I also really emphasize that there is no product that's going to 100% prevent concussion. I think that's really important to emphasize because there was a period of time, just as an example, like those headbands in soccer were really popular. And you would sometimes hear from kids like, well, I thought I couldn't get a concussion if I was wearing this. And it's just frankly not the case. And I think really important for our athletes to understand that even if they're wearing some new product, that's not necessarily going to mean that they're not going to sustain a concussion. The consensus statement, though, does point out that there are some specific things that have been shown to be helpful in prevention of concussion. So they support the use of mouth guards in child and adolescent ice hockey. I think the numbers are, it's a 28% reduction in concussions with use of mouth guards in that level of ice hockey. Disallowing body checking for children and up through most levels of adolescent hockey has reduced concussions 58%, which is a pretty remarkable number. And then limiting contact practice in American football at all levels has reduced concussion rates 64% in practice settings. So again, a pretty remarkable number and reduction, and I think important to recognize that we have come along in our ability to, and we kind of understand what we need to be doing to help reduce some of these rates. And then there was also support for some strategies that seem to help reduce recurrent concussions. So those are things like the mandatory removal from play, requirements to have clearance from a healthcare provider for returning or getting back to play, and then all of the education for coaches and parents and athletes regarding signs and symptoms of concussion. I'm sure some of you here probably are involved in like youth sports coaching, have kids that are involved, and sometimes I think it can maybe be perceived that some of that concussion education is pesky or repetitive at this point for some people, but we do know that that has seemed to reduce those recurrent concussions particularly. So just to touch on, removal from play, which is probably less likely something that like this group would be involved in, but the consensus statement emphasizes the importance of removal from play, even in the case of a suspected concussion, that there are signs that we know warrant immediate removal, so actual or suspected loss of consciousness, seizure, tonic posturing, those sorts of things. I will say at this point in a lot of talks on concussion, I'll see colleagues show a video where this didn't go well. So they'll show a video where they're like, oh my gosh, look at, I think Tua's injury in the NFL was a really common video that was shown. And I think that can be helpful to say, like, yes, we don't always do this correctly, or we still need to be very aware of these injuries on the field. But I also just want to say, from my perspective, what I see clinically is that we are doing a much better job removing kids from play and athletes at all levels from play. And we know that that's really important to recovery process too. I'm going to touch on recovery in a little bit, but just we do know that removal from play immediately after suspected concussion is related to better recovery times. And I think if that's maybe a nugget to take away for your clinical practice, that when you see athletes at any level, just emphasizing in the context of concussion how important removal from play is. The consensus group did develop some freely available tools. The CRT6 is a new tool that's actually developed for use for non-healthcare providers, and so available for like coaches and parents to be able to utilize, and then an update to the SCAT as well, which is a tool for use for healthcare providers. Another sort of freely available tool that was developed from the consensus group is the Sport Concussion Office Assessment Tool, the SCOT-6, which is something I use pretty commonly in office. It's to be used kind of at those time points beyond sort of acute injury, so 3 to 30 days of injury. It's a multimodal tool, so things like demographics, prior medical history, symptom checklists, there's some brief cognitive tasks, the VOMS is on there, there's some like blood pressure assessment as well. And I think the really nice thing about this tool is, again, it's multimodal, but you can sort of break out sort of the pieces that might be most helpful for you in sort of your setting or clinical practice. And it really does help to get at sort of different points that maybe can help for consideration of like where to refer next, where to next steps for recovery, essentially. So rest and exercise. The statement emphasizes that the best available evidence tells us that recommendations for strict rest until complete reduction of symptoms is really not beneficial. So, like specific to an athlete population, it used to be years ago that we would say you can't do any kind of exercise till you're back to zero or back to your baseline with symptoms. And we know that that's really not shown to be helpful. And I do think this is an area that is certainly generalizable to the general public, in that beyond those first 2 days after an injury, it's really okay for people to start moving. So doing some light intensity aerobic exercise like walking or light stationary biking, and then increase that from that point as tolerated. Screen time is something I think a lot of parents come into the office with their kids and want me to say, no screens, no video games, no phones, those kinds of things. Frankly, the research really doesn't support the need for complete reduction of screen time beyond those first 48 hours. And at that point, really just monitoring sort of how symptoms are responding to screen use. Alongside rest, it seems as though sleep disturbance in the first 10 days after an injury is a risk factor for more persistent symptoms after injuries like this. And so I think, again, just something to think about in terms of clinical practice. If you're seeing somebody after a concussion and they say, I really can't sleep, it's this first week or so after an injury, perhaps really focusing next steps on that sleep, and then also considering that this might be a longer process for recovery for that person. So the research tells us that time to presentation to specialty care after concussion does seem to contribute to reduction in recovery time. So the earlier somebody is seen in specialty care seems to reduce that recovery period. And so I'm often asked, like when I meet with primary care or folks like that, like how soon do you want to see people? The reality is I want to see people as soon as possible. And I do think that referral to specialty care in the context of concussion, again, not just from kind of anecdotal clinical experience, but the research does bear that out, can be helpful in moving recovery along. The consensus statement notes there are some specific areas that may be helpful to consider for referrals. So things like if you're seeing cervicogenic symptoms, is a referral to physical therapy makes sense. Migraine and headaches. With cognitive and psychological difficulties, certainly somebody like myself, or talking about maybe mental health referrals, things like that. And then they made a very specific statement regarding recommendation for cervicovestibular rehab if we are seeing dizziness, neck pain, and headache beyond those first 10 days, which I do think is a pretty frequent occurrence that you would see that, but not yet necessarily kind of standard practice for that referral for rehab. As I said, I like to see people as soon as possible, but certainly if you're seeing concussion that's persisting or symptoms are persisting at that 4-week mark after injury, that really tells you that it's likely time to make a referral to specialty care. I think some of what can be most helpful with that referral to specialty care is the symptoms of concussion are so nonspecific, and the consensus statement notes this, just sort of lots of factors that can be exacerbated by concussion that can lead to recovery times or impact on recovery times. And a lot of times my job is saying to patients, just as an example, like you came into this injury with maybe an elevated level of depression, and what you're experiencing now maybe doesn't seem 100% attributable to the concussion. How do we kind of narrow focus maybe on treatment for your mood to help kind of move forward in the recovery process? So what do we mean by recovery? When I talk about this in office, I talk about kind of collecting puzzle pieces that tell us about recovery. Because obviously concussion isn't like, a bone fracture where we can put you under an x-ray and say, oh, looks like it's recovered and healed. And so the consensus statement notes sort of 3 main things to be considering with recovery. That's symptoms back to baseline, both at rest and then with activity. return to baseline if you have sort of availability of relevant tests. So like with a lot of our student athlete populations in high school and the collegiate level, we have baseline testing related to neurocognitive functioning as well as balance, things like that. And then has the person returned to normal functioning and things that are important in their day-to-day life. So school, work, and then back to sport as well. Again, this is an area where biomarkers come into question. We really just don't have support for the use of these kinds of things in clinical practice. And it feels like we're kind of moving in that direction and potentially getting there, but really biomarkers are primarily a kind of research protocol tool. This is not directly from the consensus statement, but I think helpful to think about what we understand about recovery. There's have been a lot of research around like pre and post-injury factors that contribute to recovery for individuals. I would say the thing that's been most consistently shown is a history of things like anxiety and depression prior to concussion, and then concurrent mood and anxiety symptoms is related to longer recovery periods. And then this is just an interesting and kind of the first time these factors were looked at in this way. So this study essentially looked at factors that tell us about recovery times, and is there a dose-dependent response with those factors. And what we do see is that when we look at things like age, gender, migraine, both history of migraine as well as migraine after concussion, and then a high initial symptom burden, that if you have sort of multiple of these factors, that we see longer periods of recovery. So if you don't have any of those factors, it seems to be we see complete recovery for nearly all individuals within the first 21 days. And then those percentages really decrease when we, again, have this kind of additive component to these kinds of factors. And so again, in clinical practice, I think helpful to think about, like, if you're seeing somebody in front of you who has multiple of these factors, providing sort of reassurance related to this may take a little bit longer, but we're going to get you recovered. Last year I gave my whole talk on return to learn, and I often say, like, I could talk about this for hours. But if I really think about that, it would just be me like on loop saying, don't keep kids out of school, like repeatedly. So it's really, the research tells us the vast majority, and this isn't a student athlete population, but student athletes are fully back to school with no supports within 10 days. We know that there's some things that can make that process more challenging. So if a student athlete has a high acute symptom severity, prior learning disability, they may need more support. But needing support at school is very different than keeping kids or college students completely out of school. And so can we help the transition back to school really pretty early on if we're providing some supports? And those things can be maybe environmental adjustments. Do we make some changes to how much homework they're needing to do, things like that, and then also delaying or making adjustments to the testing environments as well. It was just like the SAT at like almost every high school this week, and so I had to write a few notes this week to get kids, to delay when they're taking the SAT, things like that. But again, that's not complete removal from school. We really want kids back in school. Yeah, you certainly can't see that. So return to sport, really not big changes to this return to play process with a consensus statement, but real emphasis on the fact that the return to play decision is a medical decision. This happens much less frequently these days, but I did just have an athlete come in and say, well, my coach told me I could play tomorrow. It's like, well, it's really not your coach's decision. And I know you can't see this. This figure is available in the consensus statement, but essentially is walking through sort of the stages that we use for return to play, with sort of that initial getting back to some light to moderate aerobic activity, waiting for reduction of symptoms to get back to baseline before we introduce more sport-specific activity, and then working through kind of increased level of sport-specific activity till we get to full contact practice, and then back to play. Return to work was not a part of the consensus statement because, again, that was really focused on sport. But just want to bring up some considerations to think through. Job responsibilities are obviously really important when you're seeing an individual who had a concussion and we're trying to get them back to work. Do they have symptom exacerbation with work-related tasks? So can you maybe sort of mimic some things that they might be able to do or that they would do at work, see if that brings up symptoms, worsens symptoms. And then also just the symptom severity. Obviously, if I'm seeing somebody in front of me who has a 9 out of 10 headache, is getting back into a work environment at that time really going to be productive and useful? Maybe not, but how do we sort of start to initiate that process? I think 2 common mistakes that I kind of see in this related to this topic are people come in with the belief that any level of activity is going to be harmful to them. So if they're having symptoms and they're doing any activity, that's somehow doing damage to their brain. And so really helping to correct that concept. And then using sort of arbitrary timeframes, like across patients and sort of their contexts. So, always saying it's going to be 2 weeks before you get back to work. Maybe for some people it's going to be earlier than that, and maybe for other folks it might be a little bit longer. And how do we, again, sort of approximate or kind of use a stepwise process to getting people back to work? So reconsider, this is one of the times where I think they probably were a little creative in how they were sticking to the 12 hours, but this is essentially, this topic is sort of focused on long-term consequences following concussion, which is obviously a really has been for a few years now, long-term consequences of concussion. They really broke down outcomes into mental health outcomes and then neurologic and cognitive outcomes. And the other thing that's really significant, and I think they made a pretty firm statement about, is that the quality of the research that we refer to related to longer-term outcomes is not across the board really high quality, and is not necessarily helpful in our understanding of future risks for athletes. And so they really focused in on research that was provided a design that was either prospective or retrospective, and that it had both an exposed and unexposed group, which is not a lot of the research around like CTE and things like that does not kind of have those factors or rise to that level of quality. But essentially, so the consensus group commented on, again, mental health outcomes and neurologic and cognitive outcomes. With mental health outcomes, we really don't see that former amateur athletes are at increased risk for things like depression or suicidality. Specific to former professional soccer players, they're not at increased risk for psychiatric hospitalizations throughout their life. And former professional football and soccer players are not at an increased risk for death associated with a psychiatric disorder or suicide. When we get to neurologic outcomes, again, there's sort of a diversion here. With amateur athletes, we're not seeing increased risk for cognitive impairment or neurologic disorders, but this is where we do see that increase for former professional athletes. The consensus statement commented on retirement from sport. We really don't have clear evidence of factors that unequivocally lead to retirement from sport. They really emphasize, again, this is a complex decision, should be kind of multifaceted in who's involved in that decision, particularly with clinicians with expertise in TBI and sport. When I see athletes who are having this question, the things that we really consider are things like, are you more vulnerable to sustaining these injuries? Are you having longer recovery periods? And have you had an injury where following that injury you had persistent symptoms? And then the last topic here that the consensus statement touched on was just sort of how do we refine what we're doing with research and clinical practice. So there's not been a lot of that research related to parasport athletes. Pediatric populations have, by and large, been really left out of a lot of the research, prior to the last few years. And then they did include the athlete's voice. So there were athletes that were involved in this consensus process. They were not considered to be a part of like the expert panels who had, a vote in the consensus process, but they were there for comment and ability to kind of add the athlete's voice to this process. And this is the first time that that's been a part of this. So I can see our next presenter over there. So I'm just going to leave this slide up as sort of just some general points about considerations for clinical practice, but do want to just provide maybe a brief amount of time for some questions if there are any. Yeah. You talked about mouth guards for ice hockey. Yeah. What about for soccer players? So there is not clear empirical support for mouth guards for soccer in the same way or to the same level that there is for hockey. It's just been a very consistent finding in well-designed studies in hockey, but not for soccer. That doesn't, of course, mean that potentially there is some benefit to something like that, but we don't have the same level of kind of empirical support for that we do for ice hockey. Any other questions? Think back. That's a great question. So I am not aware of like the specific, so I think the question is essentially, after a second concussion, do we know what the increase in time essentially is out for recovery? Is that your question? Oh, full recovery. So the research that I'm aware of that speaks to that question really uses the kind of third to fourth concussion as the risk for sort of those longer persistent symptoms. I'm not aware of research that tells us that at number 2 that we tend to see longer periods of recovery time or incomplete recovery. Oh, thank you. And I think I completely skipped over that sort of at a related point when we're talking about prevention. So certainly the consensus statement did not comment on neck strengthening, but it did comment on neuromuscular like warm-up for athletes, and that seeming to be helpful with prevention of concussion. To your point, though, there is support that relates to like prehab, essentially, for neck strengthening. Seems to be particularly for girls and women who participate in sport. So that's sort of where our understanding of the importance of neck strength comes from. So when we compare women and men in similar sports, we see higher rates for women, and a lot of the thinking around that has to do related to neck strength. So my understanding right now, I think the kind of policies around that are the age of 12 to 13. She asked about, in case anybody heard that, sort of is there a minimum age where heading should be introduced into soccer? Okay. Well, I'm going to end there, and then next we have Dr. Scott Gailey.